Hello, I'm Norman Swan. Welcome to this programme on oral health. We're coming to you across Australia through the Rural Health Education Foundation's satellite network. Tooth decay and gum disease, dental caries, periodontitis are two of the most prevalent and most preventable illnesses in Australia. About 50,000 Australians end up in hospital each year for dental conditions that could have been prevented. And that's not to mention the hundreds of thousands of people disabled by their teeth problems, unable to eat properly, malnourished, and everything else that goes along with it. Tonight we'll be looking at what these diseases are, how they develop, and what can be done to prevent them. We'll also focus on the special circumstances faced by people living in rural and remote areas where the dental workforce shortage is particularly acute, and therefore it's you, the general practitioner, who's got to cope. As always, there are a number of useful resources available for you on the Rural Health Education Foundation's website, rhef.com.au. Now let me introduce our panel to you. Mark Tennant is Director of the Centre for Rural and Remote Oral Health at the University of Western Australia in Perth. Welcome, Mark.
Thank you, Norman.
Bruce Simmons is a dentist who's been working in government dental services, one of the few, let's hope there's a growing number. More than 30 years, Bruce, is that right?
That's true.
In Alice Springs. Welcome, Bruce.
Thank you.
Deborah Park-Bryant is a dental therapist and dental hygienist from Mildura in Victoria. Welcome, Deborah. Angela Massoy is the Oral Health Programmes Coordinator for the Greater Southern Area Health Service in Queanbeyan, New South Wales. Welcome. And last and certainly not least is Elizabeth Dodd, who's a rural doctor and amateur dentist par excellence based in Griffith, New South Wales. Welcome, Elizabeth.
Hi.
You're looking a bit uncomfortable with that title I just gave you. Many dental stories from years in general practice?
Not from years in dental practice.
In general practice, sorry.
But from years as doing work in remote Australia. When I was working in places like Cloncurry, where my definition of remote is where you fill in for the dentist and for the vet.
And you fill in for the teeth as well, perhaps. So what dental procedures have you had to do as a GP?
I've done an extraction on someone who actually had broken a tooth on a rib bone.
Did you work out whether it was a figure of eight? I mean, I seem to remember you had to work out the figure of eight movement and all sorts of movements for different teeth to get them out.
No, my worst problem was actually getting a decent anaesthesia.
Right, so you could work it out while they were numb. What does a dental hygienist actually do, Deborah?
A dental hygienist will diagnose with, under the supervision of a dentist, gum disease and can treat patients of any age. So we do non-surgical treatment of gum disease. That means scaling and cleaning, and generally the oral hygiene is, I consider, the most important part, teaching patients how then to look after their mouth and take care of themselves, making sure they keep themselves healthy, diabetes, and understanding the problems that make their gum disease worse and the connection between their gum disease and their other health issues. For example, dry mouth can be an issue, so those sorts of things we need to educate our patients how best to manage their dental situation.
So the holistic dentist is the person who treats the whole tooth and you're treating the whole mouth?
Well, we're looking after the gum part. The dentist is looking after the part he can feel and fix.
Glad to see the whole person features here somewhere. So, Angela, what does a dental therapist actually do?
And a dental therapist treats children until they turn 18, and we're prominently in a public system, but now we can now work in private practice, but we can actually...
and it varies from state to state in Australia, doesn't it?
Different, yeah. But we can actually do examinations, diagnose and treat. For example, do restorations, extractions of primary teeth, and if you're competent, you can take out permanent teeth.
How do we know if you're competent?
We have an oversight practice under the Guidelines Dental Act.
So is there anything you can't do as
We
dental?
refer surgicals and orthodontic treatments, but we actually concentrate on the prevention side of the business as well.
So that's things like fissure sealants?
Fissure sealants, oral health promotion in communities, etc.
Okay, and how much does it vary across Australia what a dental therapist can do?
I think there's only ACT that is a little bit different in that they can't take out permanent teeth, and I don't know.
There are some other variations, Norman. It's a really problematic situation.
But it's an important one because it's one of the answers to the dental workforce problem, particularly in country Australia, rural Australia.
Absolutely, and I think what we'll see under the new COAG activities about unification of qualifications around the country will flow over into dental therapists and dental hygienists, and we'll actually see some sensible situations. You know, we've got situations where dental therapists working on the border between Victoria and New South Wales actually have to do different things on, 10 minutes apart. They're not allowed to do something 10 minutes from another place. So
Even though they're trained to do it?
Even though they're trained and they're competent in one jurisdiction to do it, the other jurisdiction they're going, no, you can't do that. So there's movement to be
And what
had.
dictates that? The power of the Australian Dental Association, or what?
No, but dental is under state acts, so we actually need to get coordination between the state acts to do that, and that is a very long journey.
So just give me a sense of, as a consumer, of comfort here. At what point do you, okay, surgical, if you need a general anaesthetic, you're going to bill to a general practitioner or dentist, but what can the dentist do that you can't? In terms of scope of practice, competency and so on?
A lot more.
Well, you've got to say that, otherwise Bruce will beat you up.
We actually can do a pulpotomy, which is the coronal part of the tooth. We can remove that, but we can't do a root canal treatment on a permanent tooth, is the classic example of what a therapist can do and can't do. So we wouldn't even, if we expose the nerve of a permanent tooth, we will refer that definitely to a dental officer for root canal treatment or
and what about bridges, for example?
Definitely not. Yeah.
No fixed bridges or crowns, fixed crowns or things. Yeah, it's not part of the. It's really not very much practiced in children's dentistry anyway, but it's not part of the therapist training. And that's the key thing, I think, is what training have therapists received. And
you can put in a nerve block?
Yes, and we can take impressions for mouth guards and for just take an impression for a dentist to do an appliance for them, but we won't do the appliance for the client, but we can take the impression on the mouth.
But where you're going, Norman, is with a crisis in our workforce, like in all health professions at the moment, the opportunity to extend, to reshape what dental therapists and dental hygienists are doing are certainly there, and they are agenda items to fix some of the crisis that we're facing.
I was going to leave this to later. We might as well talk about it now since we're talking about it. What are the dimensions of the problem? I mean, Elizabeth, do you have how many dentists have you got in Griffith?
6.
Well, that's not
only.
bad.
They're looking after 60,000 people.
One thing we should say though, Norman, I mean, it may be a long-term solution, but in the short term, there aren't many hygienists around anyway. There's only been a couple of training schools around for very long at all in Australia. And the therapist numbers have been allowed to run right down up until the last few years. So it's not as though there's an instant.
They're waiting for work. Mm-hmm. Yes.
No, and like the dental force, we're ageing.
Yeah, we're ageing.
we're not going to be here forever.
Present company excluded, surely. No. So, I mean, for the time being, I mean, presumably you face the problem that public dentistry is inaccessible, huge waiting lists.
Yeah, it is inaccessible unless you're under the age of 18.
Well, just to give you an idea, Norman, in the year 2000, we were training less dentists, and I'm sorry, but less dentists than we were at the end of World War II. In absolute numbers, forget the population. We'd got to a crazy situation. The same situation had happened with therapy, and hygiene's very relatively small in numbers. So we got to a situation where, we were licking the iceberg on the poop deck of the Titanic. And then finally we decided to actually do something, and we've now increased numbers in the existing 5 dental schools and therapy schools.
New dental schools as well.
And we've opened up 4 new ones in Australia, 3 of which are located in rural and regional Australia.
So how long before you see the effects? So it's a 5-6 year program.
Absolutely.
And the other thing, just on quality, just before again we get onto, because don't worry, we're going to get onto the meat here, caries and periodontitis, don't go away. But on quality, dentists don't do a residency year. They don't do a registration year. therefore, and any medical graduate watching knows that they were qualified for nothing when they walked out of medical school, and you'd have to assume, you know, that the average dental student's done maybe 1 crown or 2 crowns as part of their training.
Yeah.
So what are they qualified for, and how good are actually Australian dentists if they're not doing a registration year?
Well, the first thing to say is, because we as schools know that we don't have a registration year, it means that the training they have during their 5 years is different to what a medical student has. And in fact, it's a real bonus, because a final year dental student actually has to treat a cohort of patients. In fact, mathematically, we know they're equivalent to about half of an employed dentist as a dental student.
So it's almost like a registration year and final year.
Absolutely. And what you can do then is you can actually place these students in locations under supervision and get care happening through student
Is
bodies.
it the same with dental therapists in training?
We do two weeks out in the field, and with the bachelor, because now it's a Bachelor of Oral Health. So
How do you get your in-practice training to know that you're competent after you've graduated?
During our training course, we're working in the dental
Clinic
hospitals
setting.
in a clinic setting.
Right.
So we're under supervision in a clinic setting during our training.
It's
Okay.
very different to medicine.
Yeah.
So the majority of new graduates, dentist graduates, go looking for supportive practices to begin with. They, in effect, get their intern.
They
year
don't want to be
3.
treated as slave labour in their first job. They want a mentor.
They do, exactly.
Absolutely.
They want, that's handled that way.
Okay, so we might come back to some of these workforce issues, but let's get down to business, because for the GPs watching, you're going to actually have to deal with some of this and look in people's mouths, as you are, I'm sure, all of you, as we speak. Mark, what's caries?
Well, caries is one of the 2 major conditions that is dentistry, really, caries and periodontal disease. Caries is a condition of the destruction of tooth substance. And, most of us actually think of teeth like pieces of concrete embedded in our mouths, and they're not actually like that. The surface of a tooth and your saliva are in a balanced ionic environment. And the ions in your tooth can actually move out into your saliva, or by some
So it's like your bones, it's a dynamic bone
environment. So dental decay is actually the beginnings of dental decay is actually the situation where the environment is tipped towards the ions moving out, and the surface of your tooth starts to be demineralised. And with that demineralisation, you then start to see the tooth surface become white.
Okay, so let's go through that process. Here's a graphic illustration of it. And so what we're talking about here are what tips that balance is the environment in the tooth, what you've created.
Absolutely.
Bacteria, carbohydrate, plaque.
Sugar and acid. From fundamentally, it's the acid process that bacteria make from the sugars that drives the ions out of the tooth surface into the saliva, and you actually start to acidically eat away the tooth surface. From there, you then get a bacterial infection of that, and the bacteria then drives the cycle faster and faster and faster.
Deborah, where do these karyogenic bacteria come from? Because my understanding is a baby's born with a clean mouth.
Well, these bacteria, basically, yes, they can come. We can get them from our family members. So basically, we're born with a sterile mouth, but we get these bacteria from all sorts of sources. Family particularly, and we get the bacteria sitting on the teeth, and they're then fed by the fermentable carbohydrates that we have in our diet. So even in a very young child, if they're having fruit juices, for example, lots of sugar in those, will sit in the plaque, the bacteria will work on them. Acid is the byproduct, drives the pH down. We get that ionic exchange where the...
so it's an acid environment that's the toxic thing.
Yes.
So what happens if you have a hot cup of orange juice? I'm told that's highly toxic.
Would make it worse, obviously.
So drinking an acid drink can make it worse?
Yes, definitely reduces the pH, makes the mouth more acid, and that's where we get the ionic exchange, and we're losing the surface of the tooth.
So a lot of people have focused in the past on trying to get rid of these bacteria or trying to prevent those bacteria getting in. Has there been any luck with that, Mark? Vaccines, things like that?
Look, vaccines have been tried for since I was born. I think there's been work on vaccines for dental decay. The reality is it's a complex mix of bacteria that gives the environment for this effect. And vaccines are, often targeted at a single bacteria or cluster of bacteria. So vaccines haven't worked for dental decay. The reality is because we now understand this balance, we can look to other mechanisms to drive.
Well, let's come to that in a moment in terms of intervention there, because I want to look at the risk factors and the overall pattern. If you look at the pattern, and given it's predominantly what we're talking about is dental caries, the pattern over the last, say, 20, 30 years in Australia, what's been happening? Because we've had fluoridation, not everywhere, but we've had significant fluoridation.
And the reality is, fluoride has been, it's listed in the top 10 public health initiatives of the last 100 years. It's been an astonishingly effective public health measure. Historically, we believed that it was fluoride that was embedded in a tooth from the inside as we developed our teeth.
So systemically absorbed, comes through the bloodstream, through the pulp, into the
built into the tooth. The reality is we know that's not the case any longer. We understand now it's actually the exposure of the tooth surface to fluoride that's the effective part.
So what does fluoride actually do?
Fluoride modifies the hydroxyapatite crystals within the surface of the tooth, and by modifying the molecular structure makes it more resistant to acid.
So it simply toughens the tooth?
It just toughens against this acid. That's all it's about. So fluoride has been an astonishing event. In fact, just to give some ballpark idea, in the mid-60s, a 12-year-old would have 12 holes, 12 for 12. Today in Australia, the average 12-year-old has something around 1 hole. So that's the sort of effect over a 40-year period that you're talking about. Nowadays, we see dental decay actually in a small subset of the population. So 70% of Australian 12-year-olds have no decay at all. No holes, they eat sugar,
Okay, so they've got none at all. So just let's take that 70%. What are the factors that determine that not having decay at all, apart from genetics? Some people just don't get decay.
Yep. Clearly fluoride exposure, we've got to make that clear, and not all Australians are exposed to fluoride, topical fluoride on their teeth.
So the fluoride critics say it's not been fluoride in the water, it's been fluoride toothpaste because it came along at round about the same time, and it's fluoride toothpaste that's made the difference, not fluoridation.
Yep, and there is some very strong arguments about that. Queensland's a beautiful sort of test model of that. It fundamentally hasn't had fluoridated water, but the average 12-year-old in Queensland...
But they've got higher DMTFs, decayed missing tooth teeth, than, say, Sydney has. Brisbane's got higher than Sydney.
But it's not 12 for 12, it's about 2.
So it's double.
So it is higher,
but at a lower level.
But at a much lower level than. So the effect of fluoridated toothpaste, has without doubt has been a very strong driver.
I think you probably have got fluoride from other sources as well, food, processed food, and so on. So that plus the toothpaste has made a big difference.
So what are the risk factors for being in the 30%, apart from not living in a fluoridated area?
And look, the core in that is the core measure is socioeconomics. When we look around to find groups of people who have high dental disease, low socioeconomic people have higher caries for kids. So, and then you look through all the factors that we talk about in low socioeconomics, about diet, about health maintenance and things.
Go on, Deborah.
We know that in non-fluoridated areas, for example, I'm from Mildura, we're a non-fluoridated water supply, the children have a 36% greater chance of having tooth decay, or the decay experience is 36% higher. We know children are about 3 times more likely to require a general anaesthetic for dental treatment. And Melbourne water supply, and generally the capital cities, apart from Brisbane, most of the country was fluoridated in the late 60s, early 70s, and this is where Mark was talking about the significant drop in dental decay. I see it daily, quite significant levels of decay, and not just isolated to the lower socioeconomic groups, but we have it generally across the board, and fluoride will make a big difference.
I remember a paediatric dentist in New South Wales once showing statistics where she doesn't do many dental clearances in children in Sydney, but she's got a busy list in Coffs Harbour which is not fluoridated, or at least that time wasn't fluoridated, with the most awful mouths.
Just recently I saw a preschool group that came through our practice for an orientation visit and a talk about toothbrushing and diet and so on. Of the 18 children in one particular group, 11 needed urgent dental treatment, and that was seen only with a mirror when they hopped on the chair. 8 of those children I would have estimated required a general anaesthetic. 2 already had abscesses, and 2 children had already had general anaesthetics.
Mark, there's been an uptick recently in dental decay epidemiologically. What's the cause? Is it bottled water? That people aren't drinking fluoridated water anymore?
Well, look at that. The upswing in dental decay, as lots of clinicians are seeing it and feeling it, the epidemiological evidence is still, still not strong. So we're still there. Now, the upswing is from 1 to, at most, 2, let's say. So it's not like we're going back to the mid-60s. The reasons for a possible upswing, all sorts of factors about diet. I think bottled water could possibly be one. The actual study was around tank water, for people with tank water, and then bottled water was a subsequent bit of that study. But the reality, I think, we should be clear here that we're not isolationists. If a kid is swapping Coca-Cola for bottled water, then, in diabetes terms and all the other health benefits of swapping to bottled water, let's just do it. Let's not be silly.
Let's not agonise over whether or not that's right.
Yeah.
Bruce, let's take us through some photographs here. We've got some photographs here of the progression from demineralisation through to plaque and so on, so we know what we're looking at.
Sure. That's, I'd guess, a fairly young person, probably in their teens. They're all permanent teeth, the ones we can see there, no baby teeth, but that probably means at least 11 years old, maybe 12. If you look at the upper teeth, with the obvious ones, you can see, first of all, the gum margins are red and slightly inflamed, which is indicative of there having been plaque, there's bacterial growth around the gums. And then underneath that, you can see a white halo around the gum margins. And on the 2 front central incisors, you can see a couple of brown spots. Well, the white halo is areas of decalcification where a combination of sugar and plaque have produced acid, which has caused that.
So if a GP sees this,
yes,
what should Elizabeth be saying to her patient, asking about, given that there's a shortage of dentists and the GPs using that opportunity for some dental prevention, secondary prevention?
Well, definitely a couple of messages, take-home messages definitely are brush your teeth carefully twice a day with a fluoride toothpaste. I mean, most toothpastes have fluoride in them, but the fluoride is what really is going to give you the major protection, and using fluoride toothpaste twice a day.
And do you need to obsess on low fluoride versus high if it's a child, or just go for full-blown?
It's only up to 6 you use the first
so foot to the floor on that.
Yep.
Angela, show us how it's done.
Okay.
This is what we're saying.
I would also want to add to just that little conversation that that case, I would definitely be advising the patient to go for the high fluoride toothpaste, 5000 plus. And I'm not promoting Colgate, but it's mainly because they're the only company that's produced this one. So this toothpaste was probably depending on the case, but
so this is early on in the course, and
that case I definitely will.
And you're going to teach your practice nurse, or the GP is going to do this to show how to do it, because nobody else is around to do it at the moment.
Now there's a manual toothbrush.
How much toothpaste do you put on the brush?
A pea-size toothpaste. And as you can see, especially with that...
Before you go any further, so let's just stop here for a moment.
Okay.
Should I have flossed before I brush?
Well, I would rather you stabilise that decalcification problem first. So
don't worry about flossing.
No, I won't. I won't kickstart the client off on a flossing program.
Washing your mouth out, because you might floss and the mirror becomes spattered, so some stuff comes out. Sorry, you're not eating, I hope.
Okay. No.
And then you wash your teeth, and then you wash your mouth out, and still more food particles go out, and you've been told that retained carbohydrate is what rots your mouth during the night, particularly when you've got no saliva left.
Okay. Don't forget we're in a drought here in Australia, so save the water, but only a small mouthful, rinse and spit.
Before you wash your teeth?
Before you brush, if you
want to
really remove
So the last thing on your teeth has got to be the toothpaste?
That's correct.
Okay. Yeah. Got it? Let's go.
Okay. If it's a battery-driven toothbrush, then we really need to make sure that it's along the gum line, all around there. run the battery-driven toothbrush. If it's a manual one, flex that muscle and let's do some nice circles, making sure that we're cleaning the gums as well as the teeth all the way around.
And
okay.
Inside and body.
And don't forget, inside, next to that tongue, clean. And the calculus or the tartar tends to settle all around these bottom teeth. So we need to have a little focus there.
Right. So hard or soft?
Soft and...
Soft bristles?
Soft bristles, toothbrushes. And this is really good for adults as well. I wouldn't
So
go,
a circular movement on the gums.
Yep, circular movement on the
Tooth and gums.
tooth and gums.
I often recommend
Massage.
children's toothpaste for my adult patients. Small head, soft bristles, nice and easy to get right to the back of your mouth.
Toothbrush.
The small
Children's
brush, rather.
toothbrush.
Sorry, yes, the brush.
Normally, I'm of a sort of medium pressure sort of person.
Are you?
Because
Right.
I think I've watched some people brush in such a way that they haven't removed the plaque.
But isn't
It's just
it
being
the
so
case that
gentle
with some of
on
these
themselves.
electric toothbrushes, you're seeing people with quite damaged, traumatized teeth because they've been going at it too hard?
I find that more
people can do it
likely
with a
in
manual
toothbrushes
brush.
with manual brushes, particularly medium or hard.
So the electric toothbrush is just a steady move round, making sure the gums are there, but not a sort of zip round.
That's correct.
And you do the occlusal surface and the inside surface. Okay. And you don't wash out at the end, you just spit it out.
Rinse, take
pump.
2 minutes.
No, I really do believe it's all in the brushing, making sure that it's not about timing, it's about making sure
It's
that
about getting
every
it
single
done,
tooth in
Doctor.
the mouth is actually brushed
Can I
properly.
be controversial here?
Everything.
And just say that
2
the
minutes.
evidence is that it's the toothpaste, the fluoride in the toothpaste that is reducing tooth decay. It's not... The toothbrush is the mechanism by which you put this toothpaste into your mouth and spread it around. And then if you swill it round and try and get the fluoride wherever, into the plaque, wherever it can go, that is your primary tooth decay defence. Protecting your gums, brush your teeth to remove plaque.
So cosmetic.
So your brush is actually helping your gums, but your toothpaste is really, and this is why we're talking the 5,000,
Yeah.
it's really the toothpaste that is the primary, the fluoride in the toothpaste is the primary prevention.
Let's go to our next photograph, which is of plaque. Take us through that one, Bruce. How would you know that that's plaque?
Well,
Do you have X-ray vision as a dentist? Do you?
we have very bright lights, and even with my 60-year-old eyes, I probably could see it in a dental chair, but I'm not sure that I could see it here. I don't think I can see it here.
So it's presumptive with the swollen gums.
Exactly. I think if you look around those lower incisors there, you can actually see that they look sort of bulky and red and sticking out and don't look normal. And often clinicians like us, when we're walking down streets, we look at people's mouths and we don't see the plaque, we see those sort of gums and we know they've got plaque on their
Probably
teeth.
what the patient notices is that they bleed when they brush, and their natural reaction is to avoid the area. If it bleeds when I brush it, I'm not going to brush it again.
And the answer is
So-
the reverse.
Yes.
So how critical is plaque to dental caries? Deborah?
To dental caries, it may not be as important to remove all the plaque. It's more important to get the fluoride there. But for gum disease, it's vitally important to remove the plaque.
Well, we'll come to gum disease in a minute. So plaque is like what, the glue that holds the bacteria? What's the story with plaque?
Plaque is the carbohydrate and the bacterial load. So that's what it is. Its relationship to dental caries is that it produces the acid that dissolves the tooth substance. So the plaque is the bacterial and carbohydrate load.
But removing it doesn't necessarily do the job.
It doesn't do the job completely, no, but breaking it up is important as well.
Most tooth decay occurs between the teeth, which is what used to be an argument for flossing, and in the grooves of and pits and grooves of the back teeth, both of which, the evidence suggests you can't remove plaque, particularly from the pits and fissures. It's too narrow. A toothbrush doesn't go down into those narrow areas, and between the teeth is a similar sort of argument. So again, I found it pretty controversial at the time, but the boffins will tell us that plaque doesn't cause removal of plaque with a toothbrush won't really have any major
Because the
effect
problem is
on
the bacteria, what you're
Yes,
eating,
yeah.
and so on.
Yeah.
And if you
Diet
remove
is-
that pressure off the plaque might be there, but the plaque is harmless.
Well,
Yes,
plaque's
rather
not harmful, but to our gums, it has an effect on our gums if we've if we've got...
So let's go to the next photograph, because this is where we've put in a reveal of how much plaque was there on that previous slide. So it's quite a lot.
What that does, it's a particular disclosing solution that discloses a young plaque as pink and older plaque at least 24 hours and probably later in a purple. So it's got a special double feature, if you like, and that shows where people have been, where plaque has been accumulating for a long period of time, and it might be sort of areas where you'd be concentrating on telling.
So Deborah, when you get your little pick out and you sort of flick off the scale that's on your teeth, is that just cosmetic?
No, that's actually plaque that's been left undisturbed that actually mineralises and becomes hard. It can't be removed easily by the patient because it's just too hard. That last slide that we saw shows where the plaque accumulates, and it primarily accumulates along the gum line. We're very good at brushing our teeth, not particularly good at cleaning along the gum line. So we need to, if we're removing the plaque to help maintain gum health, we need to get along the gum line.
So we've seen demineralisation, which was the first slide, which really probably is the next slide after plaque. And now let's have a look at dental caries full blown. Just talk us through this shot, Bruce.
Well, lower in size of teeth, lower front teeth. A whole lot of numbers on there. I think they're indicating various things. So I think number 2 sort of shows some decalcification, which is early caries, but so far hasn't found a hole. That's right. 3, 4. 4 is interesting because it's got quite a black cavity there, which looks pretty ugly, but black caries indicates there's been quite a bit of remineralisation, which is not a bad thing. And then that tooth, the other tooth going further around, seemed to have some, above the black margin, some really quite...
I don't know much about dentistry, but it doesn't look good.
It looks bad.
Okay, so that gets us to the full thing. Talk to me about fissure sealing and the role of that, because is that the same thing as fluoride application, or is that a different story?
No. Fissure seals is a clinical prevention procedure, and it initially started off for prevention of decay in permanent teeth, but in high-risk children we're now actually sealing the deciduous molars. So, but it basically, it's what it says, of sealing out decay, and the products that we're using at the moment, it's a glass ionomer, and it actually has slow release fluoride, and that can actually, again, like Mark said, we're putting the fluoride back into the saliva or the oral environment, and every time you brush your teeth, if you had an acidic oral environment, the fluoride can be combined with the...
So it actually works with it.
Yeah.
And what's this varnish we're seeing there?
Sorry, Norman, there's actually a really interesting story about fissure sealants that adds to that. Fissure sealants are actually, you put them in the fissure of newly erupted teeth and that. Lots of them actually fall out. But we actually know that even when they fall out, because they've had a slow release fluoride into that risk area, the fissure, those teeth are actually protected even after the fissure sealants dropped out. So fissure sealants are actually a very positive, constructive way of protecting high-risk parts.
And how do you apply it? Is it complicated?
Oh no, very easy. It's like, this is how we explain it to the young ones. Anyhow, we shampoo with poly etch, and then we dry the tooth, and then we flow the glass ionomer into the grooves or the valleys of the tooth.
So the indication is high risk people with young people with deciduous teeth, with their permanent teeth.
That's correct. Yeah.
Individual risk, particularly with Aboriginal children, a lot of teeth are hypoplastic. They're poorly formed due to childhood illnesses and the like. So any tooth that looks like that, straight to it with a fissure sealant, which is more than a fissure sealant. Someone said it's a mountain and valley sealant. You basically cover the tooth with a protective layer and hope that that will particularly reduce the likelihood of decay.
So let's talk about the special needs of Aboriginal communities, which you would have a particular expertise on. Mm-hmm. How does the story we've told so far differ for Aboriginal communities and Torres Strait Islander communities?
Well, I'm talking primarily about the Northern Territory, and I think, and probably truly remote areas, but toothbrushing, although we've tried very hard over many years to get that established at home, hasn't happened.
So any toothbrushing that generally occurs in school and the like, which we try and do. Caries rates are very high. They're particularly high in young children, and they're quite high in the permanent dentition as well. Now, Norm, get me back to the point you're asking.
Well, just the particular circumstances which are different from what we've been seeing. So really, it's a question of severity and prevalence,
and the fact that some of them, like two key messages, which we would usually apply in say in a private practice, would be brush your teeth twice a day with a fluoride toothpaste, and reduce the sugar and sweet intake. And both of those are extraordinarily difficult to address in communities. So you're tending to run towards school toothbrushing programs, preschool toothbrushing programs, and the other part of that slide there, which we've gone past, but had varnish, fluoride varnish, and we've been doing research in the Northern Territory painting fluoride varnish 6 monthly on children aged 18 months to 4 years.
Is that easier than fissure sealing?
It is. I mean, the major advantage is it doesn't have to be done by a dentist or a therapist.
So an Aboriginal health worker could
Aboriginal health worker or a doctor or a nurse. And you could be doing it, and I would recommend it, you could be doing it 6 monthly from 18 months through to 16 years or whenever, really. Because the other areas of prevention are so difficult to control at this point.
Aboriginal people are massively overrepresented in the extent of prevalence and incidence of dental decay. For example, on some West Australian data, which is equivalent in Queensland as well, 3 times more likely to end up for a general anaesthesia for dental decay in infants and primary age kids, and that's even when the access to services to actually get them referred to the tertiary service is not there. So it's an enormous problem.
So let me take the lucky 12-year-old who's got no caries.
Yeah.
When they're 70, will they have caries? What's the natural history?
Well, the natural history does depend on the cohort we're talking about, and we don't really know our young people, we don't really know what they're going to be like at 70. But in general, as Mark was saying, there's been this, as the cohorts have been ageing, the fluoride people have been coming through, and we 60-year-olds have benefited from that. The caries rates have been much less, but caries, the National Survey of Adult Oral Health demonstrated that for people over 35, there was only 5% who hadn't had caries, and in fact, on average, people are getting about 4 or 5 decayed teeth every 20 years. Okay. So people are still getting decayed teeth.
Saliva. My understanding is, Angela, saliva is really important here. Dry mouth, bad for the teeth.
Saliva is very important because it keeps the oral environment, it buffers the environment, helps clearance for all the food, like you said earlier on about rinsing, and also it acts like a reservoir for all the fluoride, calcium phosphates, etc. So it has a healing.
Medications would be a significant cause of low saliva load, wouldn't it?
Well, we issue a lot of medications which reduce saliva. We've been issuing lots of antidepressants. Old people get anticholinergics, particularly to help them with their dribbly bladders or their dementia. Antihistamines will be in full use this month because spring is here in the south, and they're all going to dry the mouth.
And dry mouth is a decimating process. You can, in 3 months, you can have every tooth in a person's mouth breaking down towards gum line through dry mouth.
Yeah, I think we've got a picture of one of those that we can show, which is somebody's mouth after salivary dysfunction.
Yeah, so
so that's presumably something like autoimmune disease that can cause that.
Absolutely. Any process that dries the mouth actually puts you at higher risk, be it a good game of football or whatever. Dry mouth puts you at risk.
So Angela, chewing gum is a good thing, isn't it? And particularly for saliva.
Chewing gum actually stimulates the saliva glands to produce more saliva, and that's a natural defence.
But there's an Australian chewing gum that's calcium enriched, which is supposed to be good too, isn't it? Or is that all just marketing?
No, it actually is, Norman. It's sorry, Bruce, but it's an Australian invention, and basically it's a neat part of whey, of curds and whey, the whey of milk. that can actually tip the balance back towards the tooth. So it has CCPA in it, it has this stuff in it that actually can drive ions back into a tooth and actually regenerate some of those early lesions.
And you've got some saliva assist products.
There's 3 on the market that we know of. I'm not promoting any of them, but it's just so that people are aware that there is aid and help out there for those with dry mouth. They're lubricants and just helps.
And that pink one's the same stuff that's in the chewing gum, isn't it? Or not?
No. This is the same product for dry mouth, yeah. But there is, like Mark was saying, there is tooth mousse, and there's one new on the market. We're not promoting again, but it's the one that is available, and it has fluoride plus the casein or the phosphopeptides.
But going back to chewing gum, any chewing gum is going to do the job. Some might do it better than others. Sugar-free, yes.
Yeah, sugar-free.
Thank you for that that correction there. If a mother refuses fluoride tablets in an area with no fluoride in the water, can the mother use full-strength toothpaste, NeutroFluor mouthwash daily? Will these be enough to prevent caries? Deborah?
The issue of fluoridation is a public health issue, and in a fluoridated area, if the fluoride tablets, by the way, are not part of the fluoride regime and recommendations anymore. As we were talking earlier about fluoride not being as effective taken systemically, that's part of that argument. So fluoride tablets are not recommended anymore, and water fluoridation is seen as being the most effective form of fluoridation. If somebody didn't want to use have fluoridated water, they could drink bottled water if they wish, and yes, they could use ordinary fluoride toothpaste to get their fluoride from that source.
Fluoride tablets are off
They're not recommended.
Off the menu.
They're not on the recommendation anymore. No.
Is there any cancer concern? I mean, another question is people asking pharmacists. These questions are from a pharmacist. About whether there's a cancer concern with oral fluoride supplementation.
In fact, this very question came up only yesterday in Mildura. We had the information session where the state government is proceeding with fluoridation of the Mildura water supply, and those very questions came up. The research that has been done, comparisons with Queensland, who are non-fluoridated, and with states that are fluoridated, there's no significant difference for all of those. Generally, the concerns that are raised, the osteosarcomas, and there are a number of those particular concerns that are raised. Probably the primary concern for most people is that the water supply is being fluoridated, sometimes against the wishes of the individual, and you've got to look at public health issues, whether the benefits to the greater majority of the population outweighs the objections of the individual.
There's some really nice Cochrane review work and systematic meta-analysis around the issues of cancer and fluoride and the pros and cons of fluoride, and all of that international work says that there's no real data around cancer effects in fluoride.
Elizabeth, what's your commonest prescription for osteoporosis?
It's biphosphonates.
Have you seen a case? We've got a question here about osteonecrosis of the jaw. Have you ever seen a case in one of your patients?
No.
Have either of you two dentists seen a case?
Oh, we've had one in Alice Springs, one case, which it's certainly concerning when it happens, and it draws attention, but I think overall the message is that it's well, Mark would probably better explain this better, but it's a pretty rare event still.
Let's just explain for anybody who's not heard about it. We're talking about really somebody who is on, if I understand it correctly, somebody who's on bisphosphonates, has a dental procedure, and the tooth either dies or doesn't heal properly.
Usually it's an extraction.
The bone in the jaw.
Extraction and then
it can be either mild or severe depending on that. So the other question, and so it's much rarer than the media might have promoted it.
To some extent, and the interesting thing is the early work was done on patients who had very high dose bisphosphonates for
intravenously.
Cancer and things. The low dose for osteoporosis story is, there's still...
So it's different if you've got myeloma.
This is probably a great opportunity for GPs to ask their patients, have you had a regular dental check? What's your dental health like? What's your periodontal health like?
So is the recommendation for someone like Elizabeth, before she starts somebody on Fosamax, to actually send them off to the dentist?
We would think that was the
best. That is in the
best.
therapeutic guideline.
That is the recommendation.
That is done before starting.
So the question from this pharmacist is, does clindamycin help? She says she's seen dentists using it.
Is that for antibiotic
for the treatment
cover?
of osteonecrosis?
I'm not aware of those.
Don't know the answer to that.
Any effects of salbutamol, of Ventolin on the teeth? That's another question.
Drying mouth.
Dry mouth.
Dry mouth?
Yeah, and the issues
And
that surround that.
Dry mouth.
Okay, so is there anything better in terms of anti-asthmatic medication that's good, or you just got to live with it?
You've got to use your preventer regularly.
Okay, so focus on the topical corticosteroids. It might help your periodontitis and the same periodontal disease as well. I'm sorry, I'm just keeping going through these because lots of good questions. I've read about a product called Dentist in a Box that people can keep at home and use if they lose a filling or break a tooth as an emergency.
I've reviewed the Dentist in a Box for remote
So this
work.
isn't about dead dentists, this is actually first aid, is it?
It is very much basic first aid, and I think it is primarily for people, middle class people who've got a filling falls out or something like that. It's not designed for acute.
Right.
Use in acute situations.
So this gives you something to stuff in the tooth while you see the dentist.
Until you see the dentist next time. You've got a sharp edge or something like that.
Right.
Yep.
So it's okay, but not definitive.
It's okay for
Right.
certain particular use.
Another question. I've read that xylitol causes the cells of the plaque bugs to explode and die, and thus helps prevent caries. Is this a myth? That's the stuff of chewing gum, isn't it?
Yes. Oh, I couldn't say that.
So it's probably more just the chewing and the saliva that's doing it rather than
stimulation.
xylitol.
I mean, I would say about extras. When I try and offer it as an alternative to parents, if they're looking for something nice to give their children, they can at least chew chewing gum. The teachers may not like it, but it's something sweet and it does them no harm dentally at least.
Okay, a rural general practitioner from Victoria writes, I sent a question, I've got a patient with bulimia. How does this condition affect the teeth and what are the best management strategies? My understanding is this is a major issue in terms of rehabilitating these young women particularly.
We see the teeth severely eroded, particularly on the surface under where they're purging.
So it's the hydrochloric acid from the stomach.
The acid effect. They can actually almost wear the teeth down to nothing at all. The problem is when you've got a patient that's bulimic, they're resistant to putting anything in their mouth. So sometimes treating it is very difficult. So they don't want to put anything in their mouths at all.
Mark, what's the story from your point of view?
Oh, I 100% agree. It's the same story. This is all we're doing is dissolving teeth with acid.
But most important is, sorry.
I was going to say one thing in that, I mean, traditionally wine tasters have been known to wear their teeth out, and one of the things they used to do was brush their teeth after every session.
Yeah.
And that's the last thing you want to do if you've got a lot of acid in your mouth is brush your teeth, because or at least for a while after you've had that acid, because you're basically removing a whole lot of decalcified decalcified enamel away. So
wine tasters teeth central.
So you want to you putting varnishes and things like that, but not brushing.
Right.
Or have a piece of, like the wine taste, and have a break and then have a piece of cheese because of the casein.
The Swedish treatment, the mandometer treatment for anorexia nervosa and bulimia involves major dental reconstruction, as far as I'm aware, so that these kids feel that they can be rehabilitated back. And a rural midwife has sent in a fact, some of my pregnant patients report their teeth seem to fall apart when pregnant. What particular dental precautions are needed in this period?
I would recommend toothbrushing, keeping the gums nice and healthy, fluoride toothpaste, and look at.
I think the old story of the baby stole my calcium. I think we don't actually believe that story anymore, and the reality is around the hormonal processes of pregnancy modify the way you react to the bacteria in your mouth, and that can significantly increase gum disease and things. So that's the worry.
Too is women become much more aware of their own health at that particular time. They're much more health conscious during pregnancy, so perhaps are more likely to seek dental treatment, and all of a sudden find out, okay, well, I've got 2 teeth that need to be removed. It's not the result of the pregnancy, rather the attention to health at that particular time.
We will get on to some case studies in a moment, but I want to talk about periodontal disease first. So,
yes,
doctor, my teeth are okay, but my gums need to come out.
Yes, and periodontal disease is obviously the other one of the big two. The reality around periodontal disease is it's actually a disease...
What's the difference in gingivitis, which we saw in those pictures, and periodontal disease?
Quite a big difference. Gingivitis is an effect on the sort of the peripheral margins of the gums of your teeth. And in fact, probably, well, we know that nearly 100% of teenagers have gingivitis. Probably all of us on this panel have some gingivitis in our mouths at the moment. Not a destructive condition. A separate condition called periodontitis is an extremely destructive condition, and that condition destroys the ligament that holds your teeth.
So you're for the GP looking in the mouth, and you see red swollen gums. How do you know whether it's gingivitis versus periodontitis?
Well, to be honest, doesn't matter. I would automatically assume it's periodontitis, because that's probably a better assumption to make.
Does that change the management?
Not really. The management is fundamentally the same. The management is around the bacteria, the plaque. Back to that story again. The difference in this condition from caries is the plaque is the bacteria actually stimulating an inflammatory reaction, and it's the cytokine reaction.
So essentially it's an abnormal reaction to, or an exaggerated reaction
Exaggerated reaction that ends up destroying the ligament structure that holds your teeth. And, you know, as you can see in the lower frame here, the old wives' story about growing long in the tooth is actually periodontitis. What happens is the ligament is destroyed and the gums, the periodontium, moves further up the tooth in upper teeth, obviously, and therefore the tooth looks longer. Now, it is actually a one-way ticket, which is a...
So treatment doesn't work?
Treatment cannot reconstruct that ligament.
Can it stop it?
We can stop it, yes.
Doing what?
Well, this...
Can I just jump in and say that although plaque is part of the issue, smoking and diabetes in particular are... and perhaps some genetic predisposition. I mean, basically, some people get it. It's about 1 in every 5.
Well, there was a paper in JAMA from New Zealand just a few weeks ago which suggested that smoking, tobacco and cannabis, diabetes and plaque wasn't a strong risk factor, at least for people in their 30s and 40s.
Well, clinically, I'm pretty persuaded of that position. I see a lot of Aboriginal men in particular who smoke and who've got bad periodontal conditions. And there's so many people with diabetes, as you know, is very common in Aboriginal people, and the consequent periodontal condition, a poor periodontal condition, is very, very noticeable. So that practical way of I would say that's they're the underlying problems. Really.
So, Deborah, show us your wellies, so to speak.
Okay, this is a lovely set of teeth that have. We've got some periodontal disease here, and we've got when we get the inflammatory response, we have a host response, and we get inflammation, the inflammation from the bacteria that sit below the gum line, and we get bone loss, bone destruction. Eventually the tooth comes loose, and this is when patients often attend a doctor when they'll say, my teeth just don't feel right, and the teeth may actually move from loss of the supporting tissues, the bone caused by the periodontal disease. Treatment for this is to remove the calculus that sits below the gum line, make the tooth root clean again.
Can you make a loose tooth tight again?
It can in fact tighten up sometimes, but we can't restore the lost tissue. We can't restore the lost bone, and sometimes patients maintain teeth still in functional, in use, and are still functional even though there is some degree of mobility. But we can actually get the disease into remission. We cannot cure the damage that's already been done, but we can stop the disease from progressing.
And you're on a scrambled egg diet forevermore.
If your teeth are loose enough.
Anything else to show us on your most attractive model, I have to say?
We can actually see calculus or tartar build up here, progressing down the tooth.
Just hold it more square to the camera if you don't mind. Yep, that's good.
Progressing down the tooth here, and we can see the significant bone loss there. that tooth would eventually become loose, and that's when the tooth is then lost. So the old saying, the bushy out there who pulled his own teeth out with the pliers, he probably had significant gum disease. We wouldn't easily remove our teeth otherwise.
One of the problems with periodontal disease and tooth decay as well is that the symptoms appear late in the disease process. So people can have quite significant destruction of periodontal ligament and loss of bone
by the time they get to you,
without sort of it affecting their function too much, and then suddenly it happens.
Significant symptoms beforehand. No, not necessarily had any pain at all, and no significant bleeding, particularly in smokers. Smokers don't get a lot of bleeding from their gums, even with very advanced periodontitis.
The question that's come in is about tetracycline, a non-antibacterial effect on periodontitis. Is that true?
Yeah, historically, for some particular kinds of periodontal disease, they've used short-term tetracycline treatment as its antibacterial mechanism. But that's only short-term, and you can't do that chronically for the chronic condition of normal periodontitis. However, there has been some reports now that the modification to the cytokine processes that are involved in things can actually happen with tetracyclines.
We've already spoken about pregnancy, Angela. What is the story with pregnancy? Because, I mean, it used to be said that if the mother had caries, that somehow prejudiced the baby's unborn teeth. Is that true?
I think that is going back to the bacteria transfer right across.
So that's a postnatal phenomenon rather than something that happens in utero.
And we don't want to promote that too much, but basically we're saying that if the mother can actually look after their oral health, then of course, because of all that knowledge and the skill to look after her family, it'll flow on to her baby, the good practices that she's gained. So that's crucial to begin as soon as she...
And what have you got, there's another question actually that's just come in this moment about vomiting in pregnancy, hyperemesis and tooth problems.
Yep, again, because of the acidity of their, perching. Most important not to brush straight away, rinse their mouth to neutralise the environment. And
maybe some people find, as I understand it, some women find it very difficult to even put a toothbrush in their mouth when they're early in stages of pregnancy. And chlorhexidine is is a reasonable alternative to brushing for a period of time, maybe a month.
Just like knocking off the bacteria, unless they become resistant. Another question on gastroesophageal reflux. Is that a cause of dental destruction, and do things like proton pump inhibitors that reduce the acid help?
Certainly. We're going through a whole suite of conditions which are really acid entering the mouth. So
right.
Yes, is the
But there is a
to
treatment for that acid, which is getting a proton pump inhibitor or an anti.
Anything that raises the pH back up is a winner.
But there's no randomised trial.
No randomised trial around that. Can I go back to the pregnancy story, because there's some interesting work coming out around improving the periodontal health of the mother. And its relationship to then reducing low preterm birth weight.
So this is the whole inflammation and periodontitis story.
The whole inflammation story, which is a really interesting story. But the data is not solid yet, so let's not go there.
It's the same with coronary heart disease. It may just be shared risk factors rather than the periodontal disease causing it. Yeah. Let's go to our case study, one of our case studies. Your patient, Jane. Jane brings her 2-year-old daughter, Sally, to see you. Jane has just begun brushing Sally's teeth, and she's noticed that her upper front teeth have changed colour. Doesn't seem to be in any pain, and she's on a healthy diet. But when you ask her about her diet, she says she's a great sleeper. She goes to bed each night with a bottle of juice for the past year.
So mother's idea of a healthy diet and mine are obviously a little different, because I don't think this child should be going to bed with anything in its mouth. So we can't just say, no, give it a drink of water and send it to bed. We can negotiate and try and reduce the strength of this juice until it gets down to a reasonable amount. It would of course be far preferable if she gave her a drink of milk and sent her to bed.
With nothing? With
nothing in her mouth. But the thing is that at this stage we've got early damage to the teeth, and we might be able to save these teeth.
So what's the trick for examining the mouth here, Angela?
We're actually rolling out a program right across New South Wales where we're working in partnerships with the child and family nurses, and we're rolling it into some of the private practices, and we're working and getting their child and family nurses to identify spots like Jane's daughter, and so exactly like lift the lip. And
so let's just start. So the mother holds the.
Yeah. So
is Elizabeth the doctor or the mother?
She's the mum.
Right.
Oh, there you are. Okay, let's change roles. Okay, there you are.
So and I'm confused now. Is Elizabeth the mother or the doctor?
No, she's going to be the doctor identifying, because we're giving her the training, right?
Right.
Okay, so we'll just check it and...
So lying in that position, nestled in your lap, you pull back the lip.
Oh, yes, I can't, but in my lap, and the child's lying in Lizzie's lap. Yeah.
So you're invading each other's personal space a bit, but for the sake of the child.
That's right.
How old can you go up to with that sort of technique?
Up to 18 months to 2 years, depending on the child's comfort, because their comfort and their security is very important.
So let's have a look at the picture from a child like. So here's a picture actually of this sort of lift the lip technique with in the lap, and baring the lip like this. Let's have a look at Sally's teeth, or the teeth that might look a bit like Sally's, and what that looks like.
Well, it's quite interesting actually, Norman. Well, sorry. It's very interesting actually that we expect this to actually not be a major problem, and I can tell you about West Australia. West Australia, 80% of the population is fluoridated water. We have a great school dental service. We have all these things, but it's still the 5th most common cause of causing a primary school age kid to go to hospital is dental decay. So this early childhood studies is a really significant problem.
And intervenable. So let's have a look at the mouth here, and Angela, maybe you talk us through this.
Okay.
So ECC stands for early childhood caries.
Early childhood caries. And the white frosty line, right, the bottom picture, you can see the white frosty line next to the gum line. That is the initial decay process of frosty, and that is reversible. We can actually...
So yellowing teeth.
Yellowing teeth. And it's where the white line is where the plaque.
Which is what we saw earlier, where you get this in more relief.
Yeah.
So it hasn't gone very. The caries hasn't gone into forming a hole there as yet in either any of those particular
first
pictures.
Stages.
They're just the early stages.
And if you don't do anything about this, this is what it could look like.
That's correct. Yeah. Yes. And what we're trying to do is get the child and family nurses to identify these and refer them, or.
So what's the intervention? What do you do?
Increase fluoride toothbrushing, contact with the fluoride toothpaste, and start teaching the parent to change the diet, especially not putting baby to bed with a bottle, and making sure that there's only water in the bottle if they're going to use a bottle, but we're encouraging.
So is this a child a candidate for fissure sealing?
If they will be compliant in the chair, then it's a high risk.
Well, not the sort of photo we just saw. With
not the rampant caries, but if they're earlier.
But if they had caries in the front teeth, you might well consider fissure sealing the back teeth.
Normally they will.
But I do think it's important to talk to parents about how things happen. We shouldn't be jumping to conclusions about how things have happened. We should have a discussion around, what do they think perhaps has caused the hole, and does it, the holes, and are they important to them? Basically, try and get some ownership of the problem by the family, rather than just be telling people what's good for them.
And in Aboriginal communities, harness the local community and Aboriginal health workers.
All that, yes, indeed. Mm-hmm.
Sorry, Deborah, you want to say that?
A lot of parents assume that children don't need to start dental visits until they're probably 5 or 6 or going to school. Ideally, we start them as young as possible with what we're talking about. Parents and allied health workers looking at the children's teeth and identifying those that are at risk, but parents can certainly start bringing their children along for first dental visits as early as 18 months.
Assuming that they can afford private dental care.
Yes, definitely that's the situation, but there's a school dental service.
Is there evidence that dental checkups make a difference?
It allows us to identify those children that are at risk, talk to parents.
That's not the question I asked.
There is, if we can I jump in?
You can.
That National Survey of Adult Oral Health demonstrated that people across the board, adults who regularly visit, the people who are by far the most dentally healthy were those who...
But that could be because they're wealthier and higher socioeconomic class and brushing their teeth more.
Well, it's demonstrated they had quite an amount of a history of decay, as I've pointed out before, but that decay had been well managed, and so it hadn't led to tooth loss and tooth destruction. So
it's complicated making the call on this one, though, isn't it?
It is, and I'll give you the other side of the story from your homeland, from England. That
wash your mouth out.
Scotland, sorry, from Scotland. That people who went to the dentist regularly ended up with full dentures faster than people who didn't go to the dentist. Yeah. So the question about that is not simple. The old days are saying, well, go.
So it's not so much the dentist, it's what the dentist or dental therapist does and the intervention that occurs.
It's the expectation of both the patients and the profession, and that has changed. Basically, most Australians now want to keep their teeth, and most dentists have been taught to, and therapists and hygienists, to do all they can to keep them. So the old days have disappeared, but not entirely, because particularly in the public dental services where there's a lack of resources, people come in with bad teeth, the solution is to take them out. But less so in private practice.
And the other interesting thing is, in a way, Australia's school dental services has been an experiment in extending that come back every 6 months. Because most services have grown out to 12 to 18 months in parallel with the fluoride and thing. And the reality is, there hasn't been a dramatic going backwards with those changes in time. So it's a really complicated question, Norman.
Let's go to young adults. We're taking a lifespan approach here. We've started with pregnancy, we've gone to a young child, a toddler, a preschooler. Now let's go to Charlie, who's 24 years old. It's your Monday morning surgery, Elizabeth. And Charlie presents to you with a swollen left side of his face. He says that he got hit in the jaw in the pub on Friday night, and today his face is too sore to go to work. When you have a look at him, he's got a swelling over his left jaw, which is warm to touch. You can open his mouth, but only about 1 centimetre, and you also see that he's got a pretty rotten mouth underneath that. What are you going to do, doctor?
We managed to organise him an X-ray.
Okay, that shows a fracture, and one of his teeth seem to be gone too. And probably an abscess.
Yeah, I think my big concern is actually his abscess, because he's actually technically got a compound fracture. So that means he's now on a long trip off somewhere. So from where I am, that's 250 kilometres minimum, one way, to get that fixed in a very wealthy area of Australia. And if he's actually in Central Australia, then if he's Aboriginal, he may have heart disease related to previous rheumatic fever, and he may have had septicemia, and quite serious problems can ensue from this. So I'm going to look at covering with antibiotics to cover aerobes and anaerobes, and see about getting him off to someone to fix it.
So after the jaw's fixed, Bruce, what do you do about his teeth?
Well, there's a whole lot of different factors in that. First of all, assuming he can get to see me, and for a lot of people that would probably be quite a challenge. And access is a problem. It may not be the dental service. They may not be able to afford the dental service. It sounds like he's got some very bad teeth. And if he was able to come to the public dental services, I think by the sound of those teeth, the odds are that he would have some teeth out.
Really? Because conservation is so expensive?
And takes time, and there's such a big lineup of people wanting care that...
so it's only the rich can afford conservation?
That's what I was saying earlier. Yes.
What about this new Medicare item, Deborah?
The teen dental plan is quite specific. It's a preventive treatment plan. There are a limited number of items that we can that we can use here. We can do an examination. Examination is required. So we can actually tell the patient, do they need restorations or not. We can take x-rays for them. We can do a scale and clean. We can apply Fisher seals, fluoride treatments, but it doesn't include actual treatment. Now, most of these patients are healthcare card holders. They come along, and for example, I'm in a private practice. They come and they have an examination done. We go through oral hygiene instruction, telling them what they need to do to take care of their mouth. But if they can't afford treatment and need to go to a public centre for treatment, a public dental clinic, there may be a lag time between diagnosis and then treatment, if at all, if they can actually access that treatment at all.
But the fluoride could perhaps stabilise their decline.
We can help them with that particular part of it, and we can probably reduce the chance of that progressing on any further. But often these children, they're teens, they've been on high sugar drinks, they drink a lot of Coca-Cola, that's the age group. They may have extensive work needing to be done. If there's a long waiting list at the public clinic, it may in fact end up treatment for pain and extractions.
So we're creating a demand that's not necessarily being met.
Absolutely, and it's an interesting policy position, because do bear in mind that dental services are run by the state, the different jurisdictions, state and territory governments, whereas the Medicare Teen Dental Program is a Commonwealth program, so they are actually driving up the problem in the state sector. The Commonwealth are driving up the treatment problem in the state sector.
What if he'd knocked out his tooth? This wasn't a broken jaw, but at the pub he'd knocked out his tooth. Is the old milk story? Let's take us through the process.
Trying to get that tooth back in as quickly as possible is the answer, and preferably a root with a clean tooth with a clean root, and also finding it and holding it by the crown of the tooth, not the root of the tooth. You want to keep the root of the tooth as clean as possible and to get it back in the mouth as soon as possible, and have the person...
And transport it in milk if you can.
That's right. If you can't do that, put it into milk. Or you can put it
and
back in the person's
GP,
mouth.
you put it back in, they hold it in until you can get it splintered?
Yep. The dentist in a box has some aluminium foil, or you could use chewing gum or something like that, something to sort of try and help hold it in, but probably the best thing is just to get the person to hold it in if they're able to do so.
Right. Don't fancy the aluminium foil if you've got an amalgam filling on the top. Yes. You'd certainly be creating some electricity. Let's move on to our next stage in our lifespan, to Jim. And Jim is a diabetic man in his 50s who attends to see you, Elizabeth, for a checkup. He reports to you that his gums have been bleeding a lot lately, although he's got no pain. He says he's excellent with dental hygiene, brushes once a day, uses a mouthwash, but it's not made any difference to the bleeding.
My job here is to look at his diabetes and consider very carefully his diet, because what he's eating is obviously not what's best for his teeth. So, if possible, we really should be talking to the dietitian as well here, because we need much better control of his sugars, and we need a different choice of foods that are causing less damage to his teeth.
Mark, is there any evidence that better control of diabetes helps periodontitis, which is what we assume he's got?
Absolutely, yes. Diabetes, everyone knows, it affects capillaries, retinas, etc. It affects the capillaries in the periodontal ligament as well. And by damaging those capillaries, you get a driver of that periodontal disease effect. So yes. Okay,
let's go on to our next stage in life. Emma, who is 65 and has come to see you, Elizabeth, for her senior's health check. She's got some incisors. You being an excellent GP, look inside her mouth, as everybody else who's watched this programme is going to do from now on. And they seem to be loose. She's got some carious teeth, which have needed dental attention for many years, and a lot of missing teeth. She said she saw a dentist last year, but the dentist, because she thought that it'd just be easier just to have them all whipped out, the dentist wasn't keen to do this. Difficult to arrange a general anaesthetic to have it done. What do you think?
I think she's got a different view on what an older person's mouth looks like. So half the people of her age don't have any teeth at all, and to her it's quite a normal thing to choose taking out all the teeth as a choice for an end-of-life way to have your mouth. So what actually happens depends on whether she has actually got insurance cover for dentistry or not. If she can't afford to see a private dentist, then they're going to rot away until she finally gets an appointment. Some more are going to fall out, and eventually the public dental service will remove the last of them. And if she's got private care, she has some option of getting some of them fixed. But it's a thing where she's looking at a different view of what her mouth should be like.
So, Bruce, has she got a restorable mouth? I mean, obviously we haven't seen a picture of it, but do you think on the face of it she's got a restorable mouth?
I'm a little bit concerned about the loose lower teeth, because very often what happens with people who've got quite severe dental problems is we end up taking out all the upper teeth and putting in an upper denture, which is generally reasonably manageable. Most people manage an upper denture, but full lower dentures are much more difficult to manage, so we often try and sort of do a half-stage removal, and that may be something that you could perhaps propose anyway.
It sounds really radical. I mean, if she had money, is it worth trying to restore those teeth?
As you said, we haven't seen the photos. We don't know how bad you'd be wanting to take some x-rays and just make a general analysis and very much ask, well, I mean, she's already said she wants the teeth out, but that could be a reflection of the total cost of the treatment, or difficulty of getting in to see a dentist, or the fact that she hates the drill and the needles, because she's after a GA, a whole lot of factors.
But the practical thing you're saying here is that she may well be a candidate for a full mouth clearance.
Well, yeah, awful lot of people a generation ago had full mouth clearances and somehow have managed to get through life and accepted them pretty well.
But round about this age or older, they start rattling around inside your gums because it's really can get quite hard to manage those dentures because you get atrophy.
The dentures? It's possible. People seem to be able to manage. Most people who have dentures keep wearing them, from my experience. Although often the bottom denture gets forgotten about ultimately, and people just wear the top one, perhaps only when visitors are around. But they like to have something in their mouth.
It's going to get really tricky as we age as a population. We're just on the beginning of this slope, and I think as a profession, we haven't actually grasped what we're facing here. Within 10 or 15 years' time, it's not going to be 50% of the population without any teeth. It's going to be something like only 10%. So we're going to have all these people with crowns, bridges, implants, loose teeth. We're going to have these complicated mouths in elderly people. So the journey over the next 10 years is going to be around developing, I think what you've heard here is developing an understanding of what geriatric dentistry needs to be and things, and we've got a way to go.
And just on, let's assume that for a moment she's got money, and let's say she's 85 and with loose dentures. My understanding is that you can actually take quite a much cheaper option than going dental implant, which is implants that will anchor the dentures, which can be quite effective.
Yes, you can, and there's a number of that going on.
The impact of residential care if she was in a home?
Daily care, and we really need to form a partnership with the residential carers and train them up on how to just do home care for all these residents, removing the dentures, cleaning them. If they've got teeth, keep them clean as a routine.
But it's a pretty toxic environment for teeth though, isn't it?
It can be very difficult. We're talking about patients who may have
a lot of help.
Low saliva outflow because they're on
one of this long list of medications that Elizabeth told us about.
Numerous medications. Residential care, the nurses and so on are geared probably to dealing with dentures a lot easier than they are to dealing with patients who actually have their teeth.
So there's enormous pressure to go down the clearance line.
Yeah, well, once you've got patients with dementia, it can be very difficult to take care of their teeth for them.
There hasn't been that pressure actually. Taking teeth out is becoming more and more rare, but it's something that needs to be thought about, I think.
Another question here, is there anything we can do to help people who might be on medications like calcium channel blockers, anti-epileptics, that get gum overgrowth?
Well, sometimes we end up using an assistant. They have surgery and reduce the gum that's overgrown the teeth. Otherwise, maintaining good oral hygiene is probably about the only place we can go with it. I have a number of special needs patients. We've gone down that path, and eventually we've actually gone to surgery to remove some of the gingival overgrowth so that we can actually maintain some reasonable oral hygiene.
Mark?
Absolutely. The overgrowth is an overreaction to the bacterial load. So, driving down keep these teeth super clean is a winning solution.
Our next case study is Marie, who's aged 24, the mother of a 3-year-old daughter. She goes to a pharmacist asking for something to relieve the pain of her toothache, and she's referred to a dentist, but since there's a long waiting list for public patients, she goes to see you, Elizabeth. You've got a busy night tonight, and you look inside her mouth. She's got very poor oral hygiene. You find out that Marie's on a methadone program, and Marie says to you she's heard that methadone rots her teeth. Doctor?
The methadone's not actually the rotter of the teeth, but on a methadone program you'll serve methadone syrup, and the methadone syrup is traditionally mixed with orange juice, and it's then drunk under supervision, and there's just your methadone, your orange juice, and you've left acid in your mouth. Then the methadone has got a side effect of drying out the mouth, reducing the saliva, so we've got less saliva, and then the underlying problem that she's on the methadone program is always associated with a chaotic lifestyle and an inability to be organised.
And the last thing on the mind is fluoride toothpaste morning and night.
Yes.
You've got a program going, haven't you, Angela?
We've got a program going. It's called Great Whites, but we've actually worked in partnership with the drug and alcohol and support case managers. And when the program kicked off, we were only expecting 10 clients out of 100. 96 clients out of 100 have actually accessed the oral health care and kept all their appointments. And the other significant thing is that out of this 100, we actually had 25 children, and the children of these clients had low decay rate, which was brilliant. But because of the caring program that was provided, they felt they're very aspiring. They felt that they could keep their appointments, come for the oral health care, and it's been quite a successful program. And this program, with the workforce issues, is actually managed by a volunteer dentist, a retired volunteer dentist. So that's another group of people that we're not accessing.
And there's a whole group of other people that we've alluded to and just don't have time to go into who have special needs as well.
Yeah. But most important for this group, we're not trying to get the fluoride toothpaste. Well, we are giving them fluoride, but our key message there is after the dose to please rinse their mouths with water. And if we can get that going, then that's...
So, Elizabeth, what do you think is the role of the GP in oral health in the country?
I think it's important to remember that it's part of the whole patient. We look inside the mouths of many, many young children because they've got upper respiratory tract infections, and we're looking at tonsils, and we don't look often enough inside the mouths of the adults. And we need to be doing this and looking for those early signs to remind people about their oral health, and that if they can take better care of what's there, we might be able to manage until we get more dental therapists, hygienists and dentists on track.
Well, that's a good final message. Angela, what's your take-home message?
As health professionals, we really need to advocate for water fluoridation and get that toothbrush and brush.
With the fluoride toothpaste?
Fluoride toothpaste, yeah. So
and don't worry about the flossing, and make sure the toothpaste is the last thing that hits the
simple.
mouth. Yeah, I've got that. Good.
Keep it simple.
Deborah?
I would say to every parent, look in your child's mouth every single day. If you see something that doesn't look right, it doesn't brush off when you brush their teeth, have a look, get it seen to. Let's deal with it while it's in the early stages, find out what's going on, see what we can do with it.
Bruce?
I've agreed with all the suggestions so far, and I've only got one other, and that is perhaps to take an active interest in encouraging more dental professionals into your area. I mean, I think professionals as a whole need to see themselves as a professional group, unless they're working together to sort of try and get a good regional representation together, then the region may well be running down.
So be a bit collegiate. Welcome people in. Mark?
I suppose my only addition to the fluoride toothpaste story
is a bit of fluoride.
It's a bit of fluoride toothpaste, but the other thing is, the messages we are talking about are no different to the messages of the diabetes programs, the cardiovascular programs. They're all about diet, improved general health, and I think if we can be in that, stop smoking, all those things, they're the same messages.
Thank you all very much indeed. I hope you've got a lot from tonight's programme, which we mouthed on about oral health. If you're obtaining more interesting information about issues raised in this programme, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. Don't forget to complete and send in your evaluation forms, and please register for CPD points by completing the attendance sheet. Our thanks to the Department of Health and Ageing for making the programme possible. And above all, thanks to you for taking the time to attend and ask so many questions. I'm Norman Swan. Bye for now.